This conference will now be recorded.
At this time, I'd like to introduce you to our speakers, John Bain and Lori Daigle. Stroudwater Revenue Cycle Solutions President John Bain has over 25 years of experience in healthcare financial management and consulting. His focus has been on Chargemaster auditing, revenue cycle initiatives, and hospital and physician practice management. He has extensive experience with solo practitioners, large group practices, small community hospitals, and large academic institutions. John has led initiatives to increase physician and departmental productivity, to implement physician-specific and hospital-wide revenue cycle protocols, and to develop Chargemaster maintenance policies and procedures. He has successfully grown gross revenue and net reimbursement through combining operational improvements, Chargemaster effectiveness, and efficient business office protocols. Lori is a certified professional coder with over 20 years of experience in medical insurance claim processing, medical billing software training, and healthcare financial management. She focuses on coding and business office auditing and training initiatives, revenue cycle improvement, and hospital and physician practice management, as well as research and development of periodic updates to support coding, billing, and other departments in compliance with regulations and requirements. Thank you for joining us, John and Lori. At this time, I'm now going to turn it over to John.
Well, thank you very much for that introduction, and welcome everybody. We truly appreciate you spending a couple of minutes with us today to kind of talk about some revenue cycle fundamentals, and we really understand how valuable your time is. And what we've tried to do is create a conversation for you here that, regardless of where you happen to be on your revenue cycle journey, we hope that you pick up some ideas. We hope that we challenge you to think maybe a little bit differently when it comes to your revenue cycle and your Chargemaster. Inspire you to really raise the levels of expectation and quality throughout your revenue cycle, which will facilitate wonderful customer service to your patients. And most importantly, we want you to have an action-minded mindset. So as we start going through today, we really want to go over, and again, for some of you on this, I mean, we're going to kind of repeat some stuff that you know really well, but I think good practices are always worth repeating. So we're going to talk a little bit about core components and functionality, and just make sure that everyone's on the same page with things. We want to summarize what we're seeing as best practices across the industry, and how people are actually using their Chargemaster processes and their revenue cycle processes as a real competitive advantage to really help with their cash flow, lower denials, and increase overall reimbursement. We are really big advocates of accountability and ownership, and you'll hear that throughout our conversation today. We want to have a quick conversation in regards to some 2020 updates that happened, and we want to allow this for you to kind of use this as a validation point in your process to see just if these questions and these new opportunities that are happening based on the final rule submission in 2020, do the participants in our revenue cycle know about them? Have we taken the steps necessary to prepare for them? And if not, why? Just try to figure out. And lastly, we're going to, throughout the presentation here, we're going to try to bring in some case studies and some findings from the field, and have some conversations just around. So hopefully you'll be able to see yourself in some of these things and make it so that you look at things and hopefully find ways to make your revenue cycle work for you rather than for you working for your revenue cycle. So when we get a lot of conversations and calls from hospitals, we get questions saying, you know, I've got an issue with my revenue cycle, or my Chargemaster, I've got issues, or you know, my business office just isn't producing the results that I want. The reality really is that most hospitals and physician groups really have a lot of different revenue cycle needs, but they use very much generic and catch-all phrasing, you know, to describe those concerns. And we find that a lot even internally when people are trying to have a conversation. Often there's a misunderstanding or a misalignment with what revenue cycle means in the facility. And there's a direct correlation with the effectiveness of your revenue cycle and the communication that is happening throughout your organization and the ability and understanding of what revenue cycle actually means in the hospital. Often when we get into places, there is an us versus them mentality, and oftentimes the reason why there's an us versus them is because people just don't have an understanding or can't empathize with what other people do within the organization. So first off, I think it's really important for every hospital to have a very specific definition and a concept of what revenue cycle means in their facility. And when we talk about it throughout this presentation, what really we're thinking about is that the revenue cycle comprises all non-clinical activity that surrounds the provision of services to patients. Best practice revenue cycles use results and outcomes to govern the quality of actions and inputs. All components of the revenue cycle are interdependent, requiring the consistent feedback, attention, and participation of all revenue cycle participants. Whenever we have folks that use sort of that level of definition, it immediately gets rid of us versus them, but also focuses the attention on one area where there's a lot of inputs being put in and quality control, which surrounds the Chargemaster. So ultimately, the goal that we're having within our Chargemaster in our revenue cycle process is to facilitate the development of a data-driven, quality-focused, and customer-centered revenue cycle. And one of the things that I want us to look at our Chargemaster as is really from a data-driven standpoint, really important. All of the data points kind of emanate out of that. But look at your Chargemaster as a way to insert a level of quality and absolutely look at it through the customer's eyes and have a sort of a customer-centric view. Unfortunately, the reality within most hospitals is that rather than having a true revenue cycle, what they've got is they experience pockets of revenue cycle activity that are independent and provide little or no guidance to assist improvements. So we've got a lot of people working really hard, but oftentimes we're not all pulling in the same direction. So when we look at things to achieve the highest quality and customer satisfaction, when we look at other areas and other industries, you know, when we look at the construction field, you know, builders that are going through and building houses or skyscrapers, they understand that they've got to be excellent at the foundational elements, not just good at it, they've just got to be excellent. And that starts with an expectation. So the most successful contractors are really known for their attention to detail and quality. So the same is absolutely true for the revenue cycle. So successful revenue cycles are based on strong foundational concepts that support each other and contribute to success, right? So revenue, it goes from the perspective of the Chargemaster, pricing, how you use those two components and how you capture charges, all the way going through how to, when patients come through, registration, scheduling, going through encoding, right? All the way through to business office and ultimately to customer service. All of these items are absolutely interdependent with each other. And often when we get questions regarding, say, my business office just isn't doing what we need it to do, oftentimes it's because the Chargemaster or the revenue cycle processes at the front end really aren't contributing to the overall success. So why is that? So we look at it and say we're in one of the most complicated industries there is known to mankind, right? There's nothing easy about what we do here. But what we do in a lot of hospitals and physician practices, we do everything we can to make the complicated more complicated. So by definition, instead of just trying to figure out the easiest path forward, we insert obstacles. We make things overly complicated. And part of the reason is that hospitals address problems, not causes. So we deal with the fire that's in front of us, but don't necessarily take the time to go back and figure out why it occurred. So there's an awful lot of time that has to go with that, and that's one of the reasons why when we talk to clients, why haven't we addressed those issues? It's because I just don't have the time. Well, we need to figure a way to be able to make sure that people throughout your revenue cycle are doing and addressing the problems, but at the same time figuring out why those problems occurred. The issue that we have in hospitals is that the solutions to those problems, are often layered on top of each other without addressing the reasons, right? So we kind of build these things up and we think we're addressing it, but we never get back down to that root cause, which causes it's a lot of frustration because these things we end up getting sort of like Groundhog Day, right? So every day we end up having the same issues over and over again, even though we think we're addressing those issues, but because maybe we don't have a process of accountability or ownership, we're not able to get back to that level of the department to kind of help with the inputs from a revenue capture standpoint, which can affect our outputs. So the majority of revenue cycle issues that we see across the industry are really caused by flaws in foundational components. And generally speaking, the three legs of the stool that your revenue cycle sits upon really become the Chargemaster, pricing, revenue capture, and control, with the Chargemaster being the brain, right? So again, looking at it from the perspective of complication, our goal really has to be throughout our process, whatever it might be, Chargemaster control, pricing, revenue recognition, coding, how do we simplify the processes to make sure that we generate consistent outcomes that are dependable, rather than going through and making a very costly process, which at the end of it, we may or may not have the consistency that's necessary to say that we know and we are in control of our revenue cycle process. So really, let's just go over a couple of fundamental concepts. The Chargemaster is the foundational element upon which the revenue cycle is built, okay? A lot of folks throughout your hospital may have a limited idea or concept of what the Chargemaster is, but what ends up happening is it doesn't define the importance overall. So it is important, regardless of your role within the organization, to make sure that all of the people within your department, your revenue-producing departments, understand the role of the Chargemaster and how important it is to not only the outcomes, but to budget reliability and customer service. So when we look at the description, from the Chargemaster overall, it is a critical component for patient communication, pricing, revenue recognition, budgets, coding, billing. If you look at it, that's your entire revenue cycle. It's all built on having a really good, strong foundation. So in order for a hospital to thrive, it has to have best-class Chargemaster, period. And I don't think any of us are just interested in having a hospital or a revenue cycle that is just successful or it gets through to the end of the day. We really want a revenue cycle that thrives, that we're proud of, that we can defend to patients and show that we are best class. So all of our revenue cycle components that we're going to talk about down the road, they're all built on that solid foundation of the Chargemaster. So all revenue cycle participants really need to be familiar with the construct of the CDM and the process for ongoing maintenance, implementation, and quality review. Oftentimes we go into hospitals and we ask, who's responsible for your Chargemaster? And departments will say, I don't know. All I do know is it's not me. It's them. So our goal is we need to make sure that the department heads look at it and say, you know what, it is, it's me. So that takes a commitment through the entire revenue cycle to ensure good communication and expectation. So the reality really is that the Chargemaster in a lot of organizations, it's someone else's responsibility. And when we look at it, this oftentimes comes into nursing, where they come through and they say, I'm just a nurse. I don't have anything to do with that, even though all of the activities that they provide and the wonderful care that they provide our patients, the only way for us to really make sure that they get paid for what they do is making sure that we've got a representative Chargemaster. So we need everyone to participate, and we need to make sure that people understand this isn't, a low-level data entry function. This is the most important concept part of your revenue cycle. Okay? So ultimately, when we go into your billing system, it is the brain of your billing system. It is the central component. And it's built through a whole series of screens within your billing system that compile to make sure that all of the results that we send to the payers are correct and are representative, okay? So basic things are just the charge code, description, revenue code. It's amazing when we go into hospitals how very few people understand the importance of revenue code. Also don't understand that different payers want different things. Your Chargemaster coordinators absolutely understand that, but often, radiology doesn't understand, or maybe the emergency room or ambulatory infusion nurses don't understand that there might be different ways to report the same service. So there's an education concept that has to go through. The most important piece is that the system must have the ability to be able to create an electronic file that you can download and manipulate and use for quality control. They are the ability to do that in your systems is the first component of quality control and ongoing management and reporting. So one of the things, and I'd like to bring in Lori on this, to go through just really quickly on some of the core concepts of the pieces within the Chargemaster, and in some of the areas where there's a little bit of misunderstanding when people are going through and using those things, and what resources they really need to be able to have at their fingertips. So Lori, can you take a couple of seconds and just kind of go through that?
Sure. So the primary elements of the Chargemaster are, of course, the item number or the CDM code, and that's a facility-assigned mnemonic. It can be sometimes the CPT with other characters associated with it, because you might have the same CPT in multiple departments, and this really has to be unique to one service line item. Sometimes it's the next available code, which can cause confusion because there's no consistent methodology for assigning that number. The item description is usually some truncated version of the description of the CPT or HitPick code. The important thing about the description is it has to make sense to everybody looking, and it has to differentiate between all other descriptions and codes in that same code set. Lots of times people will use something that can be used over and over again. It's important to note that the short description in Medicare Addendum B and some of the short descriptions in AMA repeat themselves for different CPTs. So we want to make sure we don't just use that short description. The AMA also provides a 48-character description that is always unique to an individual code. So that's a good resource to go to stay consistent and to make sure that you have names that make sense and differentiate between all other CPTs in the same category. The revenue code now is actually a 4-digit code, but it's a leading 0, so we tend to ignore that 0 and still think of it as a 3-digit code. And it further categorizes those CPTs and HitPicks into services performed. Drugs would be in one range, radiology services in another, CAT scans in another. Labs have several ranges depending on whether it's hematology, microbiology, immunology, etc. So every CPT can be assigned to a particular revenue code, and you want to make sure those pairings make sense. Some CPTs may fit into multiple categories, in which case you choose the one that you would report that service on your cost report. And that's how you would assign that revenue code if it takes more than one or has more than one opportunity. The CPTs and HitPicks
are those 5-digit or 5-character alphanumeric codes that are used to report the service to the payer. The payers on outpatient services only see those CPTs, diagnosis codes, etc. And we've advanced to the next slide.
Yeah, so Lloyd, I just want to take 2 seconds. Maybe you can spend a couple seconds, because what I do get a lot of questions from clients is just, how, if there is a differentiation between HitPick and CPT for the same service, there sometimes is confusion about how do they make a determination on, which to include in their Chargemaster. Should CPT always be primary? How do you make a determination to be able to do that, and how often are the CPT and the HitPicks updated? Are they on different schedules?
They're on the same schedule, and the reason why you might have a CPT and a HitPick that represent almost the same service is because Medicare owns HitPicks, and sometimes they want more detail than is provided in the CPT. So for that reason, if you have a CPT and a corresponding HitPick, the HitPick should be your primary code. It will be the code that requires more detail. And then the CPT can be the background code. In the case where, for instance, like a flu shot, where HitPick gives a specific code for immunization of a flu, pneumo, hepatitis, etc., and CPT only has one code for primary immunization and one for secondary. So because they both have more than one, you cannot set up a secondary code for those. You actually have to go payer specific, depending on whether they want the HitPick or the CPT. But most of the time, you would want your HitPick to be your primary code because it requires more detail. They're on the same schedule where major updates happen on January 1st of every year. HitPick changes can be made quarterly, and CPTs rarely come out with other codes throughout the year, but most of the changes happen January 1.
So, and that makes a lot. So that actually begs the question. So when we go through and we talk to clients and we just try to incorporate what the Chargemaster's role is within the revenue cycle, again, a lot of the understanding of people within the organization and what they look in, the lens by which they look at the Chargemaster is really based on their perception of what the Chargemaster does. And when you start going through, there's an awful lot of logic, training, education that goes into the areas that Lori just talked about. I mean, successful Chargemasters don't happen by accident. They are meticulously cultivated with years and years of experience to understand all of the intricacies about what Lori just mentioned, and those are just a couple of core components within the Chargemaster. So it becomes really important for people to understand that the Chargemaster represents all billable services, supplies, and pharmaceuticals that are provided to your customers. It translates those services into formats that the payers will recognize and reimburse, and likewise, it communicates those same services to patients in an understandable manner. So the Chargemaster is really a marketing device to your customers, because you want to appear that you have control, but it's also the primary function of making sure that the services you conduct and provide to patients that you're reimbursed for. So the first component of a proactive, data-centered, internal Chargemaster review process, and 2 words in there, it's proactive and it's data-centered, right? The review process has to center on the ability to create an electronic download of the Chargemaster, as we talked about before. A lot of hospitals take this entirely for granted, and there are absolutely people on the phone that, based on their systems, some it's much more complicated to get, some much more easy to get. But the reality is, when we talk to people, that 6 out of 10 clients have a difficult time creating a file. And part of the reason is that they create the file today and then they create it tomorrow. And aside from some similar, some additions that may have happened in that 24-hour period. Sometimes the format's different. Sometimes they had, 18,000 lines, and the next day they download it and it's got 16,000 lines, okay? So we need to make sure that there's a way to get that electronic format out in a consistent basis. And out of the 4 that have a really, an easier time in getting it, about half of those need to reconfigure the download to be able to make it so that the file provides information. So think of it this way. You want to use your downloaded Chargemaster as a quality control device. You want to make it so that you can get to the answers quickly and consistently. So whenever we go into a hospital, difficulty in generating the Chargemaster file is really the first symptom of a subpar or underperforming revenue cycle, because it is the core informational piece about what your revenue cycle is doing. And if we've got something that is a file that is disparate, or it is not consistent in how you look at it, or in some cases very difficult to manipulate, it gets in the way of a well-functioning revenue cycle. So, and one of the things, when we go and talk with folks, and so when you download the Chargemaster, what do you want to do with the Chargemaster? So we get that and say, we look at the Chargemaster, and I always ask them, okay, so what do you do with it? And we look for things, okay? So what do you actually look for? And sometimes there's not a consistency in what you're looking for. So what do we want to do? We want to make sure that once you get that file, you're able to manipulate the data into a consistent format for analysis. You want to be able to have the ability to merge into the Chargemaster a series of internal control variables that facilitate comparison and identification of issues. Some people have a deleted code file that they've got available that they overlay. Some people take Blue Cross or Medicare fee schedules. There's a whole host of things that you can create that you go and use this as a check and balance. And when you get really good at this, this isn't something that takes hours. This is something that could take, an hour a week or an hour a month to make sure that at least everything is in control. The control variables, they really allow you for focused review and research. And that's the important thing. Whenever we're looking at our Chargemaster, we want to be focused. We want to make sure that we examine every line in the Chargemaster to identify issues. And many line items may have multiple issues. Sometimes you want to segregate, and one day you'll look at supplies, one day you'll look at pharmaceuticals, other times you want to look at departments that have assigned CPTs or HitPicks. And then when you get those things, what are we looking for? So I pulled these things out. We want to look at descriptions. And Lori had a great comment a couple of minutes ago. It's got to make sense to you, your patients, the payers. So if you download your Chargemaster and the department looks at it and says, I don't even know what this is, that's a problem. We want to make sure that it conveys a message. The revenue code assignment, we want to identify deleted codes. I can't tell you how many hospitals we go into that have deleted codes within their Chargemaster. There's codes that maybe have that are procedural descriptions, but they lack CPT assignment. Or have missing codes because we use an alternate code hierarchy, but it's not consistent because we've got multiple people who are managing the Chargemaster, and not everybody does everything the same way. We've got some departments that have the same CPT multiple times in the department, often respiratory, that we have to ask why. Are we using this more for statistical things? Are we using it for orders, or are we using it for revenue recognition? So when we go into the field, really what we find is that a lot of the Chargemasters, they're not representative of the current service provision. So Chargemasters are like these huge black holes. Things go in and they never come out. We spend all of our time in the revenue cycle fighting the fires that are in front of us, and one of those fires is to add things and not take things out. So all issues found within the Chargemaster really can contribute to subpar revenue cycle functionality. It is a fact. There's no way around it. Okay? Many of these items contribute to denied claims, delayed reimbursement, compliance concerns, or customer service issues. In a lot of hospitals, that line item right there, people, when they say, I have business office issues, that's what they've got a problem with. It's not necessarily they have a problem with their business office. It's the problem that their revenue cycle isn't generating the results that are necessary. So just as a way to look at things, we recently did a large community hospital that had about 8,000 lines, okay? And this was a hospital that had not had anybody look at their Chargemaster in almost 10 years, okay? But when you talk to CEO and CFO, they felt as though the Chargemaster was in control. And you can see the issues that were happening across the board. I mean, the number of deleted codes, the number of duplicate or pricing issues. So they had a whole host of issues, codes that were priced at 0. And one of the things that we find is that these types of issues in the allocation and distribution of those are really, consistent along most of the reviews that we look at. So the hospital that we're referencing here had deleted codes going back to 1998 that were active. These weren't ones that, this wasn't a system that you had to keep the codes active. There was no way to delete them. They absolutely had a mechanism to inactivate codes successfully. Their response to that is, well, wait a minute, it's okay. We just know that we won't use them. It's all right. We know they're there, but God knows no one's going to do. But the reality is the 558 codes were used 1,875 times, accounting for $187,920 in gross revenue, or realistically, $188,000 in denials. They were blaming that on the business office. They also had a lot of codes that when they downloaded the Chargemaster and looked at it, they had the following descriptions that were in there. I like, deleted, do not use, absolute, do not use ever. I guess that was used once and they, tried to fix that and put the emphasis on the ever. Dr. Smith's stuff, like that. Procedure, I like that. So what did you do today? We did a procedure. Or we did a supply, or we did a drug, or catch-all other. When we went through these items with them, again, their response was, it's okay. We've got processes in place to ensure that these don't get used. Well, the problem was that those 9 codes that had those descriptions got on bills 865 times over 12 months. So at that point, CEO and CFO took a step back and said, well, maybe we don't have the same control as we really think we do. So when we look at things and we talk to hospitals all across the country, really the issues that present themselves surrounding Chargemaster concerns repeat, okay? And so the issues, the concerns, and the excuses, they repeat overall, okay? And ultimately what we have is we've kind of characterized most of the revenue cycles into 4 components. We've got hospitals that are the false start, we've got some treadmill hospitals, we've got excuse maker hospitals, and we've got doer hospitals. And we'll go through a couple of these things, and what I want you to do is just keep an open mind and just see, where do you fall in with these things? So when we look at it from a Chargemaster perspective for the treadmill hospital, they have limited revenue cycle meetings, but they never assign ownership or accountability out of those meetings. It's the same meeting over and over and over. It is Sonny and Cher coming up at 6 a.m. on the clock, and it's Groundhog Day over and over and over again, okay? The facility culture is that's the way we always do it. I've got a card that is laminated, and every person that comes through and gets hired gets that card, and they understand that when they show up at the meetings, they use that card, and it says, hey, why do we do that? Well, it's the way that we always do it. The same revenue cycle improvement projects get brought up over and over and over again with no resolution or improvement, and this includes denial management, whether it's physician documentation issues, customer service policies, stop times, and ultimately when we look at this, the business office runs the revenue cycle and the Chargemaster process for these treadmill hospitals. Likewise, we've got the false start type hospitals. They try so hard to get meetings going, but they always run into something more important and places the Chargemaster, revenue capture, denial management on the back burner. You get a lot of frustrated people in these hospitals. The department heads are generally frustrated because they never make any progress across any area that they're looking for, but at the same time, they're being asked to be accountable and are having expectations put on them, but we can't get out of our own way. The revenue cycle operations are usually controlled by the latter process components, so usually it's not only business office this time, but coding as well, but it bypasses the departments. Revenue cycle reports are non-existent. Departments feel that no Chargemaster ownership or accountability of process. They just don't feel involved. This is that hospital where, who's responsible for the Chargemaster? I don't know. It's just not me. The facility has ineffective customer service policies. You got a lot of complaints. You got a lot of denial issues. And then, interestingly enough, the budgets in these hospitals are provided. They're not discussed. So it's a top-down, and the departments really feel as though they don't have a lot of input. Then we go through and we've got the excuse maker, right? So we talk and have meetings with them. I know this is important, but no, you don't understand. We don't just have the staff. I mean, good gracious. We tried to get started, but we never get any support. And I laugh sometimes because that statement is told me by the CFO. I'm trying to figure out what support he needs. We don't have any denials. And I say, yeah, you're the one. Congratulations. We're a critical access hospital. None of this applies to us. We are treated special. I don't have to worry about the Chargemaster. Anything I put on my bill will get paid. Don't worry about it. Our system is awful, and it can't give us the reports we need. All right, so now the system becomes our crutch. This is my Scotty from Star Trek. We're not billers and coders. We're nurses, darn it. We don't have anything to do with business. And you look at it and say, who are you? I'm the nurse. I'm the sole caretaker, for my patients here. But they think that they're outside of the revenue cycle. I'm the department head. I don't have anything to do with the Chargemaster pricing or revenue capture. I just don't. That's somebody else. That's the billing office's job. Talk to them. Then the last one, I always enjoy, and this is after I'm sitting in the room with them, they tell me, I'm sure we're doing fine financially. Administration would let us know if there was an issue. And then I look at them and say, well, I think they're telling you because we're having a conversation about the Chargemaster today. Then ultimately, we've got the doer. And ultimately, we really want all hospitals to be in this category. They've got meetings. They assign Chargemaster responsibility. They set process expectations. The only way that you can set an expectation and assign responsibility is if the people who are running the revenue cycle have a good, solid understanding of it beforehand. They hold people accountable. Revenue cycle focuses on the patient. Everything is done through the patient's eyes. Quality and control are vital components. You have to ask yourself, if I have revenue cycle meetings, how often do we discuss quality? How often do we discuss customer service? Reports are informative, they're detailed, and they are consistent. The revenue cycle is an administrative concern, and that is really the most important part of all of the conversations we have. The Chargemaster has to be an administrative concern. It can't be a byproduct. It can't be a side conversation. It can't be that I'm not sure who does all what. It has to be, I know. So from a CEO, a CFO standpoint, it's critical. Success in your revenue cycle depends on this being an administrative concern. When that happens, it allows the CFO, CEO, revenue cycle director to empower people within your process to make a difference. And ultimately, when all of those components happen, there becomes no difference between the quality of clinical care and the quality of the business processes. They are intertwined, they are one, and that makes it so that we are a best practice hospital. So ultimately, when we look at across the country, 10% of the hospitals really fall into doers, 35% become treadmill, 20% are false start, and 35% are excuse makers. But, here's the thing. There's not a perfect approach to this, okay? We all understand hospital and physician culture is a powerful force. We have to figure and identify the culture that's employed and figure out how can we take on that culture to make sure that we get the positive results out of our revenue cycle that we want. Being the doer doesn't absolutely ensure Chargemaster's success. Likewise, being an excuse maker doesn't ensure Chargemaster failure, right? It just takes longer for the other three categories to achieve success. And Lori, one of the things that, I think when we go to a lot of places, you see and live this, but what I'd be interested in hearing, so when you're trying to get some of these people to become doers, what's a top level recommendation or a piece of advice that you give them to be able to go through and get into that 10% doer category?
Well, one thing I find is that knowledge is power. People really want to do the best job they can, and when they don't understand how their current practices are impacting the organization, they don't see it as a problem. But when they get a detailed understanding of the entire revenue cycle, where they fit in and how they impact the process, they tend to be much more energized and much more willing to contribute to make a difference.
No, I totally agree. And I think part of that is that, you need to take steps to really control your Chargemaster. And I think part of that really does become making it that administrative priority. So, when we look at things, administration's just got to ensure that all of the revenue cycle participants understand the role and importance of the Chargemaster to the financial stability of the hospital. To be successful, a Chargemaster review, whether it's internal or external, it does not matter. It's got to be done in departmental chunks. It's impossible for you to go through and fix everything at the same time. And Lori, I think one of the things that, we often talk about is that hospitals go through and they really try to fix everything all at once, and then they don't go through and they fix anything because it's really difficult to fix everything at the same time. So when we try to make things an administrative priority, what have you found that's been successful in getting the attention of CFO and CEO to allow them to create that culture of making it administrative priority?
Well, that's a really good question because it differs from organization to organization. Sometimes it's the realization that you may have the same service priced dramatically differently across your organization, or it may be that you have entirely different services lumped into one category and priced the same. An example of that might be something like a lesion removal. I've seen organizations that price that at a flat rate of about $150, even though some lesion removals might reimburse $4,000 and others might reimburse $40 or $50. So understanding within that particular organization where their shortfalls are and how to prioritize that and bring it back to the front.
And I think that makes a lot of sense because, so in the example that you just talked about, how do we find those issues? We find it through, the administration supporting people throughout the process to ask questions, to be inquisitive, and not be afraid to raise issues if they find them. And how do we do that too? They can help provide guidelines and framework for bringing those issues forward. I mean, to reward people for identifying potential gaps in knowledge or problems or issues or gaps within our Chargemaster. As part of that also is that we've got to assign responsibility. There's got to be a demand for quality, and that goes perfect with the lesion conversation because it's not just having it in your Chargemaster. Is it priced appropriately? How are we using it? And ultimately, is there the commitment to customer service to make it so that all of those components that we're getting it right? So when we look at these things, administrative support and empowerment, it gives the hospital the ability to hit the Chargemaster reset button. When we talk to every hospital, we want it to make it so that everyone can say, this is ours. Most hospitals walk around with a Chargemaster that it's like almost us wearing somebody else's clothes. It doesn't fit. We need to make sure that the Chargemaster is representative. And how do you do that? So you've got to have a consistent and controlled system generation pathway for your files. And most of you have this, but we take some of this stuff for granted. We've got to make sure that the files that we generate to control our Chargemaster are consistent. They've got the right fields that people then know what to do with those details when they come out, and that it has all representative services. And it can't just be looked at by one person. This is how you end up disseminating it to your revenue cycle teams, making department directors responsible for their Chargemasters. You know, we want to make sure that there's a consistency in the architecture of the file. Often we end up seeing that the file gets generated and handed out to departments, but it's in such a disparate format that the departments, they just don't know how to deal with it. And the departments come and say, look, I'm not a technology person. I don't even know how to use Excel. But if we found a way to make it consistent and educate them, we might have a little bit more success. Likewise, this all goes in line with the fact that both Lori and I are huge advocates for departmental accountability and ownership. You know, administration plays the primary role in this. They've got to ensure that every department, through revenue cycle teams, takes accountability for and ownership of their departmental Chargemaster, period. To be successful, a Chargemaster process must center around the people who provide the service. The days of the business office run or the back end of the revenue cycle running the revenue cycle, it's over. I mean, you got to make sure that the people who are providing care to the patients, who are interacting with the patients and can empathize with what's happening, have the ability to control the contents of their Chargemaster, and at least at a minimum have a very strong voice in making sure that we have the ability to control quality and customer service through their input. So ultimately, Chargemaster success depends on departmental control, consistent review, auditing and discussion, assignment of responsibility, accountability, and ultimately commitment to customer service. We want you to always look at the Chargemaster through the patient's eyes. A lot of times when we do those things, it eliminates the us versus them. We want to make sure that if you're having revenue cycle meetings, you incorporate Chargemaster review components into every meeting. Every meeting that you have should be agenda-driven anyway, but it should end up having at least 10 minutes to discuss Chargemaster issues, whether there's updates, deletions, issues that were represented through a complaint that was received from a patient. They didn't understand the service. We need to make sure that we use the departmental reports as a check and balance on the efficacy of the Chargemaster. Take a look at the descriptions that you have for the services in your service analysis. If you don't understand it at the departmental level, how is the patient going to do it? How does the business office do it? We need to make sure that we're incorporating all of these components. You know, we need to make sure that we ask the simple question, would the patient understand? You know, also, use the denial management process to review the Chargemaster Foundation to ensure it's leveraging success rather than contributing to denied claims or diminished returns. And that's one of the things, and you know, Lori, I think you can speak to this really well. We've got a lot of clients that the denials are emanating directly out of the Chargemaster versus it being a pure business office issue. You know, and I think that's one of the conversations that we have routinely with people about, you know, how do we get those denials back to the proper people to fix?
Right. So an example recently was a transposed code. I got a request from the business office to set up a system request to auto-adjust a code because it always denied for medical necessity. The description appropriately described the service that was intended to be performed. And since labs don't know CPT codes, they didn't know it was a problem. But the numbers in the CPT had been transposed, so what the payer saw was something completely different. And it wasn't root cause back to why they were denying, it just came to they always deny. They always denied because it was a diagnosis HitPick mismatch because it was the wrong CPT.
Yeah, exactly. And you know, and the funny thing is that so some of this stuff, this never gets caught. You know, it's a lot of things that get caught by accident. So, you know, I think one of the things that we always try to tell people is that the Chargemaster will only be as good as the attention and focus that's placed upon it, period. You know, if you haven't had a comprehensive outside review, it should be done really a minimum of every 3 to 5 years. But more importantly, there should be full internal reviews that should take place on an annual basis. And I would say to you that you should be having it almost on a monthly basis and using what we talked about, the mechanism of that revenue cycle team to act as a check and balance on your revenue cycle and your Chargemaster. You know, departments should be reviewing their full Chargemaster on a quarterly basis. The best practice is that they get it every month and they just make sure that everything is working. You know, successful internal reviews, really they depend upon systematic, controlled review guidelines. What am I looking for? Why am I looking for it? Report expectations. Importantly, an expectation for action. You're going to go and do it. Revenue cycle team participation, and really tracking, trending, and scoring. So if I fix it, we track it, we make sure it never happens. Now, a really good check and balance on that is the changes that effectively happened come January of 2020 that really do have some impact into your Chargemaster process. So, Lori, if you can take a couple of minutes, let's just go through, and what I'd like everyone to do is use these screens and this conversation as a way to go back to your processes and validate. It'll tell you whether you're in control and on top of things or you've got opportunities to improve. So, Lori, just take a couple of minutes and go through some of this stuff if you can.
Sure. So the AMA created 248 new CPT codes effective 2020. When new codes are created, it's usually because either technology has advanced and new services are being combined, and sometimes you'll see they're replacing things that we always called unlisted codes. So we should always do a review of all the unlisted codes in the Chargemaster and the usage of those every year to see if a new code has been created to replace your unlisted code, and always update those as soon as you can. 75 revised CPT descriptions. Now, sometimes the descriptions are for clarification, and when they are, it's because the usage of the code is not always understood. Sometimes it materially changes how the code is used. For instance, it might say it now includes guidance, even though it's the exact same CPT. You always have to look at revision changes every year to see if it changes how you use the code or how you understand the code should be assigned. For instance, a couple of the changes this year are around the wound care codes and how those should be used. The same CPTs, but they added clarification and slightly changed how intermediary and complex codes should be used. Breast biopsies, reductions in mastectomies, there were quite a few changes around some of the breast codes this year. And so you have to understand if the usage changed as a result of those revisions, did you educate your users so that they know to report the codes appropriately? Or more importantly, sometimes the providers have to change how they document so that in the event of an audit, they are passing the audit. They're still documenting the service as it's intended to be reported. 71 CPTs were deleted, and that's because either new codes were expanded within those same sets. Those 248 new codes might describe those 71 deleted CPTs because they've expanded the categories. Same thing with HitPicks, 70 revised HitPicks where the descriptions were changed and modified. Sometimes that's around things like how many units of HitPick per drug J code. That is a really important thing to understand. 256 new HitPick codes, and some of those further expand upon existing CPTs. So you have to look at how your Chargemaster maps those together, comparing CPT and HitPicks. 78 HitPicks were also deleted last year for the same reasons they're deleting CPTs. So you really need to take a look at all of those. When we look at the E&M changes that were effective in 2020, and we see huge changes coming down in 2021, it's because the usage of evaluation and management services changed. We now have an opportunity to report online or digital E&M codes. I've seen this in the news a lot lately with coronavirus. I actually heard doctors on TV today saying, have a virtual exam if you can, have a telephone exam if you can, instead of going into the office. These are all new services that are coming around. There are guidelines around those codes that need to be understood. How often they can be performed, what the timing is, etc. We have codes for how E&Ms are performed, and we have codes now for services other than providers, other than what we would consider doctors, DOs, NPs, et cetera. Now, Medicare makes a distinction on these, and they don't call these E&M services, they call them assessments. And these are time-based codes available for those practitioners. We used to create statistical codes when they did screenings or evaluations. Now we have reportable CPTs. You want to advance to the next one? Here we go. For HitPick changes in 2020, as I was saying, you can use these assessment codes, and these are time-based codes, and these are for those practitioners that didn't always have codes available to them. You can go on to the next one. 2021, we're going to see huge changes in how the professional E&M services should be tracked. We no longer will have to document history and exam. The new descriptions of those codes are going to say medically appropriate history and exam when performed. The entirety of the level will be determined by medical decision-making. And the medical decision-making tables on how we arrive at those levels are changing dramatically as well. So we need to prepare for a lot of training and education around how we will be reporting E&M services as of January 1, 2021. The deletion of 99201, which is the lowest level new patient code, that is a code that is rarely used and is being considered obsolete. So we need to know it's being deleted, but it probably won't materially change the way you do business. We're also going to have some new codes for prolonged clinical staff, codes that can be used for staff other than necessarily the providers. So these are an opportunity as well.
No, that makes sense. So there's a lot of stuff that's going on. I think this is, there is good information here for you to go back and just verify, like we said, do we know about all this stuff? Are we taking action to it? Are we communicating this to our physicians, to our professional coders? Are we looking at our EMR templates? Do they even have the ability to generate some of these codes, especially as we're expanding all of these opportunities. So when we look at it, look, the Chargemaster is the foundation of your revenue cycle. Chargemaster Success does not happen by accident. It is intentional. Success depends on an understanding of the role and responsibility of the Chargemaster within your revenue cycle. It's got to be an administrative priority, and administration must empower departments to take accountability and ownership. Huge piece. Those two bullet points right there, administrative priority and accountability and ownership, that defines whether your revenue cycle is going to thrive or just proceed forward. Okay? Together with administration, departments must create a work plan for addressing issues and reclaiming the hospital CDM. The goal is to generate departmental success to eliminate it's too complicated or we don't do it this way mentality, okay? You address that through data and expectation. Policies and procedures must be implemented to govern ongoing maintenance, implementation, and auditing of codes. Just go through. You must have, if you're a best class organization, this is written down somewhere. You've got a process for the way that you are putting new codes in your system, reviewing them, auditing them, and then removing them, okay? Like I said, success doesn't happen by accident, and behavior in this process never lies. The review approach must be based on consistent action aimed at continuous quality improvement. This isn't something that we do only in even-numbered months. This isn't only stuff that we do during a leap year. This is stuff that we do every single month, and it is an administrative control process to ensure that we've got good quality. Use the 2020 updates that Lori just mentioned. Use those as an excuse to stress test internal policies and controls. Ultimately, constant informed action is the key. The only way to improve really is to start. So it's an important aspect. Do we have any questions that were brought in through the chat?
I don't see any questions that are on the chat, but I did have a couple participants raise their hands throughout the presentation. So I know, Kathleen, if you have a question specifically, as you had raised your hand. And Kathleen, if you're dialed in, it's *2 to unmute yourself, or you could type it in the chat if you wish. I don't see it coming in.
Okay. So there was a question that was asked that we had that I just wanted to bring up. So one of the folks that attended wanted to ask, we've always had a problem starting, and I'd be interested in Lori's perception. If I've got an underperforming Chargemaster and revenue cycle, where do I start? How do I take that first step?
A couple of different ways. It's always effective to break it out into departments and let the departments, as you said, look at their own Chargemaster and does it make sense to them. If not, educate them on how the Chargemaster is used. And usually when I do that, I start sitting with the individual departments, then I start to realize, and they start to realize that the Chargemaster really isn't working for them. It really isn't representing all of the services they perform. It's missing some of the add-on codes. It's maybe misrepresenting services. And so they start then to become much more engaged in the process and making sure their portion of the Chargemaster is correct. Sometimes I might do just a quick review starting with, if the descriptions don't make sense, is it because I have the wrong CPT codes, or is it because they're just being too vague, or they're using things like Dr. Smith's injection services? Then, that might be a focus. I might do just a comparison of revenue codes. Things like allergy codes, it's perfectly appropriate to have many, many descriptions to represent the same service. Allergy testing, you will need that. But in other cases, you should not be changing the description for the same CPT throughout. So if you have the same CPT multiple times with multiple different descriptions, you want to question that as well. There's a lot of different approaches to take. Usually I start with a high-level review and identify the most consistent trends within that Chargemaster and focus on those things.
So, and then I just had one other question that was provided, and it's actually from the other side of the spectrum. For hospital that is the self-proclaimed, like they really have it going. What steps do they take to maybe take it to the next level, to go from a successful revenue cycle to one that is not only best practice but allows the hospital to thrive? What's the steps for, what maybe is a suggestion to really energize and take their revenue cycle or Chargemaster process to the next level?
A good place to start is with the denial management. To start to identify those trends and to prepare regular audits to be part of your revenue cycle meetings. So each meeting should have some research planned for the next meeting. If you're not doing that, then you're not working toward improvement. So it might be an audit of a particular department or a particular process. It might be a review of prior authorization guidelines if that's what you're identifying as your issues. But you should also always have some takeaway that requires you to work toward in the next meeting.
Oh, that makes a lot of sense. And actually, I see Sherry typed in a question about which departments would be best to start with from a Chargemaster standpoint. And one of the things that we recommend is start with the ones that are most important to your organization, but also most visible, and maybe in areas that you're maybe at the most risk. So emergency room, CT, MRI, ambulatory infusion, observation. All of those departments have a lot of different revenue cycle components to them, and success is dependent upon that Chargemaster for each of those groups being complete and representative to ensure whether it is through order entry, whether it is from nursing documentation, physician documentation, all of the billing guidelines that are out there surrounding ambulatory infusion. So those departments I would start with. I think that those are ones that are easy to do. They're not ones that are like 900 codes. Lori, do you have any viewpoint on that as well? May have lost Lori. So, well, I think we're at.
Sorry, John, I'm here.
Oh, okay.
I'm here. So I was just reiterating that it's a good idea to start with the emergency room. It has so much variability and it touches so many other areas of the hospital. When I find a trend in the emergency room, I can usually take that same trend and look at those same services in other parts of the organization and fix those at the same time. Wound care is another one that I start with on top of the ones that you mentioned because it's such a growing and important service right now, and there's lots of confusion around how to properly identify wound care services.
So we have one other question that came through, Lori, from Tabitha. She asks, we're a critical access hospital, so for professional fees, I go to the physician fee schedule as a starting point for our formulas. Where would you recommend for a starting point on facility fees?
For facility fees, I would do the same thing. I'd go to Medicare's Addendum B fee schedule for facility fees, and I would start that as a baseline for my formulas.
Terrific. Well, so we want to thank you guys for participating today, but we also want to let you know that we're going to be having another conversation exactly a week from today, which is going to build off a lot of the stuff that we talked about today, but get more under the tent around strategies for making this whole process an administrative priority, really talking around communication and setting expectation, deal with instituting quality control, which is a hugely important aspect of your Chargemaster and revenue cycle process,